Okay, everyone, so before we get going, I just wanted to ask you briefly, what is your existing knowledge about dementia? Or Alzheimer's specifically, but Alzheimer's is a type of dementia. We'll talk about that. But do you feel like you know a little bit, or do you feel like dementia is all brand new for you? A little bit. Okay. Now, I will point out, we're not going to get heavy in the clinical side of things today. I'm not a clinician. I'm not a doctor. I don't want to talk heavily about all the reasons why dementia happens. We'll talk a little bit about that, but I'm not going to show you big parts of the brain and all these things that are happening. If you need some more of that training, we can schedule something in the future for that. And also, you have some further training this week that might provide a little bit more of that detail. Today, we're going to be talking more about what you should be looking out for, how to interact with people, and how to train other people how to interact with their loved ones or their neighbors or other people regarding that. So today, we'll talk about what is dementia, symptoms of dementia, the progression of Alzheimer's specifically, because it has a very specific progression that is very unique to it. Person first language and cultural considerations for this first half, which should be about an hour and a half worth of training. So what is dementia? So dementia, the kind of clinical definition of it, is a group of symptoms caused by an underlying medical condition that impairs cognitive function, causes behavior changes, and interferes with normal activities. And so what we mean by that is that someone's brain has been affected in a way that they don't behave normally anymore. Although we don't want to say it's normal, but they don't behave in the way that we expect them to behave anymore. So one of the common things we talk about, right, with Alzheimer's or dementia is memory loss, right? They can't remember short-term memories, immediate things. But it can be more than just memory loss. It can be behavioral changes. It can be processing changes, like they can't do step-by-step activities anymore, you know? You can actually have physical symptoms like loss of eyesight or other things. So it's because the brain is changing. The brain is losing function. Dementia is not a specific disease, a normal part of aging, or exclusive to older adults. So dementia is a whole different set of diseases, and we're going to give you an example of what that means in a second. It's not a normal part of aging. Although older adults are more likely to have dementia, and specifically Alzheimer's, not everyone gets it, right? We've experienced that. You've met somebody who's in their 90s and is still can process the same way they did before. But also, it's not only older adults that this happens to. There are forms of dementia that can develop earlier. There's even a form of Alzheimer's that can develop earlier. People with Down syndrome will almost always develop Alzheimer's at a very early age. It's very unfortunate. And also there's other things like traumatic brain injuries or other kinds of health problems that can cause changes to the brain that cause symptoms of dementia. So when we say it's not a specific disease, here's what I mean by that. If I came into the room and I had a runny nose, and then Bianca came in the room and had a runny nose, those are two symptoms, right? A runny nose is a symptom. But is the cause of that runny nose the same thing? What are some causes of a runny nose? Raise your hand. Eating chili. So if you eat spicy food, you could have a runny nose. What's another cause of a runny nose? Cold. You could have a cold, right? What's another cause? Air conditioning sometimes, right? Like sometimes when the weather changes, like when it's kind of cold out, your nose starts running, or sometimes even when it's too hot. What's another cause of a runny nose? Being cold, right? There's all these different reasons that our body can cause a runny nose. So if I walked in the room and my nose was running, it could be because I was eating hot wings just before we came in. But Bianca might be getting the start of a cold. Not to say that Bianca has a cold. But, right, so the same symptom, different causes. Well, it's the same with dementia. There's all these different types of dementias. There's one called Lewy body dementia. There's vascular cognitive impairment, which is when you have blood and heart issues. Come on in. Thank you for visiting today. Glad to have you here today. Feel free to take a seat. Vascular cognitive impairment, where something has changed in the vascular system, the blood system, the heart system, and that makes a change in the brain that causes dementia. Frontotemporal disorder, so a front part of the brain is having some kind of issue. Usually these are caused by genetic changes, but they can also be disease-related issues. There can be mixed dementias, where there's multiple causes for changes to the brain. There's all kinds of different dementias. So don't assume because you're seeing symptoms of dementia that somebody has Alzheimer's. That may not be true. There's different types. Again, somebody who's in their 20s who's having dementia, and that can happen, it's probably not Alzheimer's. It's likely something else. It could be, for instance, a poor medical interaction of medications that's causing that. People can develop symptoms of dementia because they're dehydrated or have malnutrition. You can even show signs of what looks like dementia because you're very stressed out. I mean, how many times have you felt that where you just got so stressed that your brain just wasn't working the right way, you know? So your brain can lose function for a lot of different reasons. So don't assume that somebody who shows signs of dementia has a symptom of dementia that it's Alzheimer's. That may not be the case. What you want to be able to be prepared to do is encourage them to go and get further health care to find out what is causing that dementia. Because again, some dementias are temporary. If I'm having a dementia because I'm dehydrated, if I drink enough water and get rehydrated, it'll probably go away. If I'm having a dementia because there's a poor mix of medications, if we get me off of some of those medications, it'll go away. But some, like frontotemporal disorders or even vascular cognitive impairment, and specifically Alzheimer's disease as one type of dementia, some of those can be permanent. Right now, Alzheimer's does not go away and it doesn't get better. There's no way to make it better. There's no way to cure Alzheimer's right now. So again, when we come back to some of those treatable ones, depression can cause types of dementia. So again, if you can solve somebody's depression, the dementia will go away. Illness, infection, or medication reaction. We talked a little bit about some medications, if mixed poorly, will cause dementia because it'll mean the brain's not functioning properly. But that can also happen if people have certain illnesses or infections, which means that if the infection is treated, if the illness is treated, the symptoms of dementia will go away. Dehydration or malnutrition, we touched upon. Think about, there's that kind of colloquial kind of term, hangry, right? Where you get so hangry that you're hungry, that you can't control your emotions, you get angry very easily. That's kind of like the very edge of where your brain is not behaving properly because it's not getting enough nutrition. It doesn't have all the things it needs. So I'm not saying that hangry is dementia. That's not what I mean. But you yourself have experienced that even being sometimes too hungry causes you to behave in a way where you're like, how come I can't control that? And we're going to talk a little bit more about the inability to control in a little bit. But so dehydration and malnutrition, if somebody gets the food or drink they need, enough of it, that will go away. Inadequate sleep. Have you ever tried staying up for many days in a row? Your brain doesn't work properly anymore. Your brain needs that rest of sleep. So people who aren't sleeping properly because of stress or other things that are going on in their life can show signs of dementia. Again, stress is another cause, right? There was one time where I had a job in my early days just out of college. And I got so stressed out. I was supposed to be driving around these like kind of high-level dignitaries who were visiting the country. And I don't know, I'm not a driver. That was just part of my job. They're like, drive this van of these people around. And they were so picky that I freaked out and I shut down. Like my brain just shut down. I just ended up sitting on a curb crying because I couldn't drive these people around. I couldn't even control because I was so stressed and my brain was just like, no more, can't do this anymore. And I couldn't control my emotions. I couldn't control myself anymore. And fortunately, my job was very kind and said, we're going to bring somebody else in to help you. They'll drive, don't worry about it. So I was lucky in that case. But the stress levels got so high that I could no longer cognitively function. My brain could no longer process information. So stress affects the way that our brain operates. And finally, sensory loss. So our brain is an active thing. It needs stimulation. And part of the way it's stimulated is by hearing, by tasting, by seeing. So one of the causes that they found, a correlation they found, is people who start experiencing hearing loss. If the hearing loss is not treated well, that part of the brain stops being used. And actually can have effects on the cognitive function, the ability for the rest of the brain to function. And it's not just hearing loss, but that's the primary sensory loss that can get tied back to dementia. So people who are experiencing sensory loss of touch, for instance, because of neuropathy, hearing loss, taste loss, things like that, it can affect and create dementias. But if you can address that, right? So if somebody is starting to get dementia because they're starting to have hearing loss, if they get hearing aids, it can help prevent that and sometimes even keep it from happening further. But when it comes to Alzheimer's disease specifically, the brain itself is affected. So we talked a moment ago about some of these things. There are temporary changes in the brain. They may be chemical or otherwise that mean the brain isn't functioning as well. But specifically with Alzheimer's disease, the brain itself is being affected. So as we look at this graphic, there's two sides, the side with normal brain tissue and the side that says Alzheimer's brain tissue. Raise your hand to tell me what a difference is you see between those two different sides of this brain. The size, right? So on the right-hand side, on the Alzheimer's disease side, it's much smaller, right? Significantly smaller. So the brain itself is losing mass. Yes?
It's also distorting the shape.
The shape is distorted. So you see this one has this kind of full rounder shape, but this one is shaped very differently, right? There's even parts that aren't there. So Alzheimer's disease is specifically taking away parts of the brain. And we're not going to get deep into the clinical part. You may have some training about that later this week. But if you're ever interested in that, reach out to us and we can explain the very clinical reasons why this starts happening. It has to do around these plaques that develop in the brain. But so it means that parts of the brain is being reshaped. Parts of it are even going away. What else do you notice that's different?
The color.
The color is different, right? In this one, you kind of see this kind of more pink on the edge, white on the inside, but you see this one's kind of dull, right? And there's even like chunks that are kind of darkened and things like that. So Alzheimer's disease is actually taking away parts of the brain. And right, think about, for instance, how you got here today. Many of you drove from South County, from San Ysidro, for instance, and you had to go across multiple freeway exchanges, right? Right. So you know there's the 905, like there's the 54, right, in South County. That there's the 94, there's the 8, all those going across the North Drive, across the 805 or 15 to get up here, right? Imagine if if you were driving up here today, right where the 94 and the 15 or the 805 meet, I just ripped that all out. Like literally, I just took the free, just ripped all that chunk out. How would you get here? You could maybe go around, right? You could maybe like get off and kind of, but it would be difficult, right? It would be hard to take away that big chunk of flow. So imagine what happens in a brain where all these communications are happening so that you can move, so you can go to the bathroom, so you can eat, so you can remember something. What would happen if you take away chunks of the brain? What do you think would happen? It would get congested, right? Parts of it wouldn't even some of it would just give up and not even be able to go through, right? So that's what happens with Alzheimer's is because you're stripping out pieces of the brain, it's losing function. It's not able to do the things that it used to be able to do. And this is where I really need to start pressing upon, and we'll talk about this a lot through the rest of the day. When people have dementia, they cannot control these changes. They can't control the memory portion. They can't remember. Their brain does not want to remember. So I've watched, for instance, I even struggle myself when I was a caregiver for my grandmother and she had dementia. Why can't you remember where we put this? How come you took the medication twice? How come you didn't remember that you took it earlier? We have to develop a compassion that their brain does not operate in the ways that ours does anymore. With somebody specifically with Alzheimer's, but with any kind of dementia, the brain is no longer functioning in the way that ours does. So to assume that they can remember something isn't helpful for us or for them. But it's not just memory. For instance, people who are in the very severe stages of Alzheimer's lose the ability to control when they go to the bathroom because your brain controls that. So they may not be able to, not only can they sometimes not be able to control when they go, they may not be able to go when they want to. So they could go to the bathroom knowing they have to go to the bathroom, but then their brain can no longer tell it to go. So they just sit there and they're stuck. And then maybe moments later they forget because their brain is so severely changed. But none of that is in their control. So we're going to touch upon this a lot today. We have to have compassion for those who have dementia because none of this is in their control anymore. Their brain no longer functions in the ways that ours does. It's not normal anymore, but it's normal for them. And we have to create a new normal situation to help them. And you are not only going to have to do that for your clients, but also help families and other people that you're working with understand that and develop their skills so that they can be compassionate. Because they may not fully understand this whole change in the brain in terms of the clinical side of what's happening, but we want to help them develop the understanding that the person on the other side who is experiencing dementia doesn't have the control over this. It's not their fault. There's no way to change these things, especially with Alzheimer's. There's no way of fixing it. I mean, we don't have a cure yet, or I don't even just a cure, but any way of even putting back a piece of a brain that's gone, right? We can take out somebody's heart and put a new heart in, but you can't take a brain and put a new brain in. So this is the challenge, is that there's no way of fixing this, and there's no cure for Alzheimer's. It's a progressive disease that only gets worse and worse and worse over time. Down here, we did make mention on this graphic, though, that part of the reason that Alzheimer's specifically causes so much memory problems, short-term memory problems, is because it heavily damages this lower part of the brain, the hippocampus. It's kind of like right down there at the base. That's the part of your brain where all your immediate memory goes, your short-term memory. So the slide that I just showed you a few moments ago, that right now is just kind of filtering around in that hippocampus area of your brain. It's down there at the short-term memory part of your brain. At some point, your brain may or may not, because it's kind of out of your control, take that and put it into a kind of long-term storage. It's like a file cabinet on the other side of the office. It might take that and move it over there. It might not, right? We don't remember everything. Our brains don't actually operate that way. Some people are lucky enough to have that sort of memory, but most of us don't, right? So that means, though, that if this part is damaged, the memories go into that short-term part and there's nowhere for it to go. There's not even a place to store it, so it can eventually be moved to long-term memory, which means that you can have challenges with medications, you can have challenges with safety, you can have challenges with driving, obviously, and orientation and getting around. You can have challenges eating and drinking and going to the bathroom. As this gets worse, it's hard to even function if your immediate memory can't really function, as the rest of the brain starts to get worse. And it's not just the memory part. Another significant problem that we won't go deep into today, but Alzheimer's specifically, although other dementias can do this, start to affect the part of the brain that processes seeing. And you start to lose the ability to see as well. Your vision starts to collapse in on itself in a way that's very scary. But most people don't know because it's so slow. And also the rest of their brain's being affected in a way that they don't even know how to communicate these issues, So keep that in mind. Especially with Alzheimer's, the brain is going away in a way that people have no choice about. And again, there's no reverse right now. There's no cure. So what are those symptoms that you'd want to look out for, you now working with the public and having clients, but also now in training other people to keep an eye out for this as they're the people in their lives that are getting older or may even be affected by dementia for other reasons? So there are some normal age-related changes that happen, right? As we get older, our bodies aren't as strong, our minds aren't as fast and as sharp. That just happens. There's no way for us to control that, and that's okay. However, in broad strokes, when you're talking about dementia, you want to see a marked change from a baseline for the individual, their normal behavior. So I'll give you an example. Imagine I'm your neighbor, and every day we walk out together on the way to work and you see me and you wave and I wave and I'm like, hey, how's it going? Nice to see you, Bianca, And then one day you see me walk out and I'm all grumbly and all these things and Bianca says, hey, and I just flip her off. Now maybe I'm just having a really bad day, right? But what if you start seeing that really, really consistently? And you've known me for 10 years and that's never seemed like my behavior before. That I used to be so kind of happy and upbeat and suddenly I'm really grumpy all the time now and never, and let's say you even try to talk to me about it. And you say, hey, I've noticed you don't seem as happy and chipper anymore. And I don't even know what you're talking about. And right, so it's even out of my control. That's a real marked change for me as an individual, right? But it might be something more subtle that you may not notice. Again, maybe you start to notice that they have more trouble going to and from the bathroom again. Like they just can't remember how to get over there, things like that. And not just memory things, but even processing. So an example I use sometimes, even though I think this crowd is probably a little too young for this, a lot of older adults used to balance their checkbook. Some of them still have that as a habit of how they track their money, right? Because they're not comfortable using a digital thing or something on a website. And now they just can't do it anymore. Something that they used to be able to do like every week or every month, they just can't anymore. Like the process for that doesn't work anymore. That's a big change from their normal behavior, their baseline behavior, right? So that's something to look out for. Is if you see a really marked change and it's ongoing, it's not just a blip, but it's ongoing, that may be a sign of dementia. These changes also should be significant enough to interfere with daily activities. Again, if I'm not able to balance my checkbook, I'm gonna start having problems managing my money, right? If I'm struggling to remember how to get to the grocery store, I'm not gonna be able to buy groceries or go to my job or other things, So it has to be something where you're noticing also it's starting to make a difference in their ability to even just function and live on a day-to-day basis, And so there's 4 primary domains that this happens in: memory, thinking, physical, and behavior. So in the memory area, a normal age-related change, as we get older, we're all gonna have a little bit more difficulty remembering names or finding words, you know? I mean, so I'm like in my mid-40s, and yes, sometimes I'll just walk into a room and be like, wait, like 3 seconds ago, I had some reason I was supposed to come here, and now I don't remember what it is. I can tell you 10 years ago, that was never a problem for me. I think some of it's also because I spend too much time on my phone, but that's a whole other problem. So that happens. We all get a little bit older, and our memory and the sharpness that we have in our brain, it just gets a little bit worse over time. And it only gets it just gets worse over time. Also, you may misplace objects more often. I mean, right, where did I put my phone? Where did I leave my keys? You know, like what was it that I was working on right now? I don't remember. That stuff happens. And if it's minor and if it's not affecting you in a way where you if you're still getting things done, if you remember 10 seconds later or something, not a big deal. Memory changes that are possible signs of dementia: getting lost in familiar places. So let's say you're with, you know, like a neighbor, for instance, and both of you go to the same mercado every week. And one day you're there with your neighbor and they say, where are we? Why are we here? I've never been here before. That happens when people start developing dementia. Is that even in a place that they should know, they no longer recognize it. They feel lost there. They can't get around anymore, you know? Hey, let's go find some apples. Where do they have the apples? It's like, we literally go to the store every week. How do you not know where the apples are? We go and buy apples here every week and now you don't remember? That's a significant change from a marked baseline. So getting lost in a familiar place and also forgetting the function of objects. So this is one that's a little bit harder to explain, but imagine if you're with somebody and they pick up their phone and point at the microwave and act like it's a remote to control a television. Or that they even take the TV remote and point it at the microwave. What's happening in their brain is that their brain can no longer differentiate the specific objects around things like that, you know? And this can be a safety issue, for instance. There's a story that some of my staff tell about an older woman who had developed dementia. She had Alzheimer's, I think, specifically, where she ended up pouring bleach into some cups and trying to serve it to her grandchildren because the bottles looked very similar to the orange juice, you know? Now, some people have been like, oh, well, she should have smelled the difference. But also what changes when you have dementia is you have sensory loss too. So she couldn't even smell the difference. So she just didn't even cross her mind. It looked like the same bottle. So all the different things that you and I would be like, that's obviously bleach, missed all those signals. But so this kind of forgetting the function of objects or misunderstanding the function of objects, you know, so like, you know, somebody is like trying to make eggs, but then they have like their duster, you know, because it has a similar shape and handle to the thing that they would use, you know, like to one of their spatulas. Like that kind of stuff happens. So if you notice that where you're like, it's very shocking, you know, and again, it's ongoing, that is likely some form of memory loss that's going on. Thinking. So normal age-related changes in thinking. So as we get older, it's just harder to learn new things. Like you probably have heard that, like I'm struggling with it. I was mentioning to some of you when you got here earlier, I would like to be bilingual at this point. With the name Joaquin Ortiz, you would hope that I would be bilingual. I'm not. Learning Spanish is so much harder than it was when I was younger. You know, like I have a much harder time remembering words, learning conjugations, things like that. So the stuff I learned when I was young, but the stuff I'm trying to learn now, it's hard. I can't remember new vocabulary as well. I have to really, really practice really hard. A lot harder than I did before. But that happens as we get older. Our brain just doesn't take in new information as easily as it used to. Also, changes in attention or concentration. It's just, as you get older, it can be harder to concentrate as much as you used to. You know, you'll find yourself being a little bit more distracted. That's okay. But possible symptoms of dementia, these are new difficulties with language, reading, writing, or working with numbers, for instance. I mean significant problems. For instance, something that'll happen with bilingual speakers is sometimes they'll really start confusing languages. Like they won't even notice that they're dipping between the two different languages. You know, like to them, it's all the same. Right? Like some of us may speak Spanglish and be able to dip in and out, but I'm conscious of doing it. They lose the conscious ability to control that. They'll start speaking in English and then go into Spanish, and they're looking at you like you should understand, and you're like, what? Like, you know, it may be a language you don't understand. And to them, it's no different, you know? But also it can be things like they can't read anymore. You'll find that people sometimes, like, their brain no longer processes the words off the page. They can't write anymore. People who have severe Alzheimer's, for instance, can't really write. Somebody who used to have wonderful handwriting, it can go away because all the functional brain skills that it takes to hold the pen and do all that is going away. And they can't process the language in the same way anymore. Working with numbers, like I was saying, balancing checkbooks or doing things like that becomes very difficult because the brain doesn't process in that same way anymore. But the real big one is like changes in judgment, insight, or reason. And what you'll really start noticing with people is that they'll make unsafe choices that they wouldn't have made in the past. That they're not as heads up about things, that they don't think through things, all of that, They can even become to some degree more impulsive. So their ability to think through things has changed significantly, more so than it should have, right? You and I, that wouldn't happen to us if we don't develop dementia. As we age, it should, your ability to think through a problem or something should remain relatively stable. So if this really changes and drops, especially if that ability is gone, that's something to look out for. Physical changes. As we get older, our vision, hearing, and other senses will be diminished. They won't be as good. Have you noticed that as you get older, things just don't taste like they used to when you were younger, Or again, definitely like we all lose hearing as we get older, to some degree. And also as you get older, you're not as strong as you used to be. It's just, your body is just not as strong as it was when you're younger, and you're not as flexible. And there's just very little, we can't control those sorts of things. But for somebody who has dementia, there's changes to the visual spatial field and other sensory processing. Like I was saying, smell isn't as good, touch can start going away, but the big one is sight. So I'm gonna give you an example of what this might look like for somebody who especially develops Alzheimer's. So take your two hands and put them out this way, kind of hold them parallel. Now, right now at this level, right, if you keep your head forward, you can still, in your periphery, still see those hands, right? Now, take those and kind of make them almost like little binoculars. Put them like this and put them in front of your eyes. Now, if we're looking out that way, you can't really see off in the periphery, right? You can't see what's out here anymore, right? Because your hands are being blocked. Somebody who has Alzheimer's specifically, as they start losing their sight, as that part of the brain starts to lose function, this is what their sight becomes like. So for instance, like if I put a bowl of soup in front of you, you might look down and I might put a spoon over here and you say, where's the spoon? Because you can't even see it next to you. Now take your hands and put them like almost like a monocular, right? You can't even see through, right? Only one eye can really see through that. As the part of the brain loses vision over time and loses the ability to process, that's what somebody's eyesight becomes like when they have very severe Alzheimer's. And there's other dementias that again can affect that part of the brain that processes sight, so the same can happen to them. But this is very common with people who have Alzheimer's specifically, what I just showed you is their sight starts to go down like this. To eventually they have what's called monocular vision. They only have that one eye. And just so you're aware, part of the reason we have two eyes is it helps us process in 3 dimensions, so we can gauge depth. If you tried to like close your eyes and try to like touch a table or something, you'll find it's actually much more difficult. It's both your eyes and your brain working together to process how far something away is. So for instance, if somebody could no longer really process both of those, can only really see out of one eye almost, would you trust them to be driving a car? What if they don't know how to stop in time for the car in front of them or the stop sign or the red light that's coming up, Let alone that they can't even see the rest of the world around them to be heads up if a car is coming crisscrossing or something else, right? And if it's starting to affect their hearing or other things, they may not be able to hear as well. So the sensory loss is very significant and problematic. The other one is that as their body starts to lose function, or their brain starts to lose the function of controlling their body, it becomes harder for them to walk and do other things. So yes, as we get older, sometimes as our bodies weaken, some of us will need canes or other things to support ourselves. People with Alzheimer's, with dementia, and especially with advanced Alzheimer's, sometimes will get to the point where they have to be put into a wheelchair because the part of their brain that functionally processes how to walk, how to move, those things, it doesn't work properly anymore. So people who have dementia are more of a risk for falls. And if you couple that also with changing sensory stuff about if their body has touch, right? Because when you're walking, your body is processing all kinds of information about how your feet feel and all those things. Like if you take away the feeling from your feet, right? Some people who have advanced diabetes have neuropathy in their feet. It's hard to walk because your feet are no longer taking in that information. Well, with Alzheimer's, you're losing all kinds of other stuff, which means that you might not be able to balance correctly anymore. Even the part of your brain that processes balancing starts to become taken apart, which means that they're much more likely to fall. So we have to be very careful about this sort of thing and think about the safety precautions that it takes for this as people are losing their ability to process information. And finally, behavior changes. As we get older, your behavior, your personality is not going to significantly change, to be honest, you know? But somebody who has dementia, they may see very, very distinct changes in their personality that are very unexpected. And they could be things that are good in some ways. So maybe using the opposite example of what I used before, what if I was just always a grumpy guy who was rushing around and suddenly I became really, really nice and seemed not really be able to process the world around me? Like, but that's a big change, right? If you've known me for 10 years and I was always like, Joaquin's always sort of a grumpy puss, and then suddenly he becomes this very happy, upbeat person, that's a little strange. Especially if you talk to me and there's no reason that changed. I didn't tell you some reason. I took a medication, I had some intervention during therapy or something. That's kind of shocking. That just generally doesn't happen with people. But the changes may also be negative. For instance, somebody who was like a sweet old lady who grew up in the 50s who like would never say a bad word starts cussing or starts talking about sex or something like that. That stuff happens where people literally like these kind of personality things that they were so rooted in are completely gone all of a sudden, you know? You may have mood changes, wild mood changes, because their brain no longer functions in the same way. So they might get mood swings. They may go from happy to angry to depressed really rapidly. And for those of you who are maybe parents, it'll sort of feel like a little kid almost, you know? Now, the thing is, they're not a little kid, they're an adult, so it's different, you know? But you'll see those kinds of things where a toddler, for instance, their brain has not built the capacity to be able to manage moods and emotions as well. Well, as you start removing brain capacity and brain ability, you can also have mood changes, personality changes that are unexpected. You might see social withdrawal. Somebody who, especially because all these things are changing and they don't know how to process it, they no longer interact with somebody. So that person who comes every day, who's always been really interactive and says hello to everybody, suddenly they just come and they just sit and they don't seem comfortable talking to people and they no longer are interacting. That stuff can happen too, which is dangerous post-pandemic, right? Because that means people might be just staying at home and not connecting with other people. And that's even worse. That actually makes it even worse for people. Not interacting with people it actually only increases dementia risk. Difficulty initiating new tasks. Now, we all struggle with this at sometimes. Like if I was going to tell you how to go and find our vacuum and vacuum a mess you made around here, it might take a little bit. You've never been to our office before. You may not know what I'm talking about. You may not know what our vacuum looks like, all those things, right? At the same time, if somebody just cannot do it at all, that's a problem because that means that their brain is no longer able to process and connect new information in a way that helps them to take next steps. And finally, if you notice big changes in normal daily routines, and so this is the one to really talk about with families, you know, is if they see big changes in mood, personality, but really normal routines that, you know, grandma always comes and she always sits down every morning and does X, Y, and Z. She always has her banana and reads the newspaper and has her cup of coffee and whatnot. And suddenly she just completely stops doing that. She can't explain why. And she doesn't even remember that she used to do it. Those are big changes that are something that people should be aware of. And I bring up all these different symptoms because you should be on the lookout as you work with the different clients that you have through PACE. But at the same time, you're going to be wanting to train families to keep an eye out for this, especially if they're starting to notice things. That, you know, my father just seems to be acting a little bit differently than before. Well, you might want to start keeping some of these things in mind and keep an eye on this because if you see some really big changes around these sorts of things, you need to go talk to your primary care doctor. You need to bring him back to PACE so we can get him evaluated further and have some cognitive assessment to see if he has dementia. So before we get specifically into Alzheimer's disease and how it progresses, do you have any questions so far about what I've kind of outlined in terms of dementia? Does all make sense?
So they have dementia. Then what can we do for them?
So, I mean, again, like I mentioned, some dementias are somewhat treatable. This is why it's really critical to try and notice these things early, is that if it turns out it's treatable, then maybe that somebody's father doesn't actually have Alzheimer's. He just actually hasn't been eating well, you know? He just hasn't been taking care of himself as well. And actually, as we fix some of the nutritional things, whatever, cognitive function starts to kind of be back there, you know? Or nobody realized, but he's been using 2 different pharmacists. And they didn't know all the what do you call it, the different medication lists that he's on. And so now he's taking conflicting medications. And suddenly the doctor brings it all together. It's like, oh my gosh, he shouldn't be taking those things together. You know, take them off, he's okay, you know? So that's why it's important to try and get a diagnosis as early as possible. When we speak about Alzheimer's is not reversible, you know, and we're going to go into that here in a sec. But so the challenge there is that if you get at least an early diagnosis, people can start planning to have the legal and financial things taken care of. And we're not going to go deep into that because that's a very, very extensive thing to do. And I don't directly teach that stuff. But more importantly, in the second half, we're going to talk about what can people do to prepare themselves for caring for somebody. And that's why I do this work. I helped care for my grandmother in my 20s. I had no education for it. And I was not a good care partner. I'm going to throw that out there. I was a bad care partner. I yelled at her frequently. I was always mad at her. You know, I think I very much alienated her, like, you know, and what I did not understand at the time, she could not control those things. I would sit there and be like, why would you do that? Her brain just didn't process the information the same way anymore. Instead of me sitting down with her and saying, Abuela, what are you doing? Well, what if we tried that over here? What if we took that knife and instead of you cutting the vegetables in your bedroom, what if we tried to do that at the kitchen table? Maybe it'd be easier. You know, just because their brain doesn't operate in the same way that ours does anymore. And I'll tell you some stories about what happened with my grandmother that'll make more sense as we talk more about some of this. They're living examples I can share with you, of course, you know, but you can't change, there's no backing out of Alzheimer's specifically, you know? So, and for a lot of dementias, many of them are just permanent, you know, because there's been something changed in the brain permanently and it's never going to go away. Mm-hmm.
So, all of it seems like you can get to a level where it's so serious or heart-to-heart concern. The one that stood out to me most was when you shared that they could, like, forget how to walk.
Yeah.
Because their brain doesn't make that connection.
Yeah.
So then, like, I know someone who the family's like, well, she can't go for her walks anymore.
Oh, yeah.
So what do you do though? The person needs exercise.
Yep. Well, there's other alternative forms of exercise. For instance, at the end of the conversation, I'll talk a lot more about the services we offer because part of my pitch today is to help all of you by having you use our services, maybe directly for your own families, but really for your clients and things like that. So we have classes here. They're called movement and motion classes. We do them every other Friday. And it's a lot of it is sitting, although there is some standing. And it's really basic kind of maneuvering sort of things. But the instructor for those, the fitness instructor, has been trained on how to design things for people who have dementia, you know, so that they're able to do those things. And of course, if somebody can't do it, they're not required to do it, you know. So there are other alternatives. And that's why it's so critical to find out early, is because especially if somebody has Alzheimer's, it's only going to get worse, unfortunately. And so when you get to that situation, that means that you're going to be dealing with cognitive decline. Functional ability is no longer there anymore. And so exercise is going to go away, and the ability to reason and make certain kinds of decisions, safety is going to change. And we have to start trying to change for those things as early as possible. And I'm going to be really honest here, and we'll talk about this a little bit in the cultural considerations thing. The reality is that a lot of the clients that all of you are going to be working with may not have the kind of means to solve all these issues. You know, for instance, for a lot of families that have wealth, they'll just put somebody in a home. And that way you have, you know, or you'll bring in a caregiver into the home. And we all know, like, bringing a caregiver into the home for 24-hour supervision, because eventually people lose all their function and they'll need to be supervised 24 hours a day, 7 days a week. That's expensive. So you either bring somebody in, you send them to a home, or you do it yourself. And for a lot of the families that we work with, a lot of families even I work with in terms of the educational side, they're not going to be able to afford those other things. They're going to have to learn how to do it themselves. So the earlier you can start planning and working on that, the better. That's why I do this work, is because I wish I had done that when my grandmother was living with us. And she was only with us for like 2 or 3 years, and then we moved her into a home. But that actually was really difficult on my family. It was very expensive. We struggled with it. And it wasn't a home in San Diego. It was a home in Fort Worth, because some of our family was there. So it was significantly cheaper than San Diego. And even then, I know the family was very strained by the cost of that. So, yep. Any other questions before I move into specifically how Alzheimer's progresses? So again, Alzheimer's, specifically the type of dementia Alzheimer's, it's a disease. And it's taking away function in the brain. These plaques are developing and it's keeping the brain from being able to communicate with itself. So again, it'd be like if I just ripped out chunks of the freeway, and ripped out whole streets and things like that. You just wouldn't be able to do things. So again, if the part of your brain that sees something has to communicate with the part of it that makes your feet move to walk properly, if there's no freeway that goes between those two parts of the brain, you can't do it. And that's all. This is only going to get worse. Alzheimer's is not reversible. There's no cure. Also, this one point, I know it's the third point here, but I just want to mention it up front briefly. It's highly variable. Some people people find out, even if they catch it early, and it just develops really rapidly, and unfortunately, it does eventually cause them to die. Alzheimer's will kill you specifically. Not all dementias will kill you. Alzheimer's will eventually kill someone. Now, lots of people will pass away from other kinds of things as well, but if Alzheimer's just keeps going, it will eventually just take away function of the brain and just shut the body down. Somebody will pass away, unfortunately. So it's that powerful of a disease. But that can happen over a few years. It can happen over 20 years. And it's just, there's no way to predict for each person. So that's one of the most important things to remember. It's not just the time, but what symptoms people develop. That's why I'm giving you this big list of symptoms. It's not the same for everybody. It's not just, oh, this will happen, then this happens, and this happens. It's not how Alzheimer's or dementias in general work. Some people develop different things. Almost everyone does have some form of memory loss because it almost always affects that area of the brain I was talking about down there at the bottom of the brain. But other symptoms past that, it doesn't happen for some people, It's just different for each person. But the wider list of things, so some people don't have significant personality changes. They just have severe memory and processing issues. Some people, their brain radically changes. So generally though, it is a slow and steady decline. Usually it happens over time. The people who rapidly go through Alzheimer's, it's pretty rare actually. So that's the hard part for families, especially as you may be taking a 10 to 20 year journey with somebody where they're just only going to be losing their ability to be functional. And again, those symptoms and the severity of it are difficult to predict. It's different for each individual. And when I say the severity is that some people, for instance, may have much more significant memory loss than others. But even the severity of some of these other symptoms we talked about could be much worse for some people and not the same for others. So everybody who has Alzheimer's, their brain is affected in similar but not exactly the same way. So just keep that in mind. That's why we want to give you all that kind of breadth of symptoms. It's because that's all the different things that might happen to somebody. But I can't tell you exactly what's going to happen to somebody. Each person, it's a little bit different. So, but we generally talk about there being 3 stages of Alzheimer's. The earlier mild stage, the middle or moderate stage, which is what most of us are familiar with, and then the late to severe stage. So in the earlier stages, you see some small short-term memory loss. This is when people usually start noticing. This is also why we do cognitive assessments to gauge people, is because almost everybody experiences some form of memory loss. And so the cognitive assessments, these tests that people take, with those tests, if somebody is doing that on an annual basis, you can start to see that they may start losing some of their short-term memory ability. And so it's a way for us to kind of gauge if that's starting to go down. But some of the other things that you might see in the earlier mild stages is occasional confusion or disorientation. And that's why it can be hard to guess, is because we all get lost sometimes. We all sort of forget what we're doing sometimes, But that's why I mentioned some of those symptoms earlier, is getting lost in a familiar place, things like that. Those may be signs of an early thing where, and maybe it only happened once. It was but that happened once 6 months ago, but that might have been the warning sign. And finally, you just start seeing problems with instrumental activities of daily living. And what they mean by that is driving, managing money, meal preparation starts to become more difficult, If you know somebody, for instance, who used to make themselves kind of elaborate meals, and then you notice they're only eating sandwiches. And when you ask them, well, how come you eat so many sandwiches now? And they honestly admit they're having a hard time cooking meals because they keep on burning them, or that may be a sign of oh, some of the stuff that they used to be able to do is now, the ability for that is no longer there, Now again, that's why you cannot diagnose somebody. I can't diagnose somebody. You got to then send them back to a doctor because they're going to look into the cognitive effects, and it could be something else. But these are some of the things that people will start to see in the earlier mild stages. That also means, though, that people in the earlier mild stages can still actually be functional and to some degree live independently, So I have a person who's been coming to some regular classes because she was recently diagnosed with Alzheimer's. So she's in the early stages of it. And she's at the right age. She's in her 60s, and that's 60s to 70s when people start to develop it. So it's unfortunate, but she's gotten the disease. And So now, though, she's still coming to classes. She writes a lot of notes. She takes some of the classes over so that she can try to reiterate the stuff. We in a lot of those classes will pass out the slides and stuff, and so she takes them with her and like circles stuff and like asks me to repeat things and stuff. It's good. She's trying to get the information while she can. She can still drive herself around, for instance. I mean, she told me that she lives kind of out by the end of the 8 over by the coast, but I've seen her in Oceanside taking a class with us. So, she's still getting herself around. So people can still function in the early and mild stages, But again, Alzheimer's is a progressive disease. So at some point that functionality is going to be taken away. And I don't mean taken away, we take it away. It's that their brain is no longer going to be able to function in that same way. So the middle to moderate stage is the one that we're all mostly familiar with when we think of somebody who we've met who has Alzheimer's. So increasing memory loss, confusion, and disorientation. So you'll right, like if you've encountered and worked with anybody who has Alzheimer's, you'll have probably experienced that of kind of like, even if you're with them for a few minutes, they don't remember things that were going on, So you'll be sitting there and you're like, oh, here's the list of things that we're going to do today. And then like a few minutes later, they're like, what is this piece of paper? And you're like, it's the list of things we're going to do today. What things are we doing today? It's the stuff on the list. Remember, we talked about it a few minutes ago. Like that functional short-term memory just doesn't really function. It's not happening as much anymore. But that can be other things. They'll get confused and disoriented. So for instance, last week, for those Friday activity I was talking about, a couple who comes very regularly for that was here. And the wife needed a little bit more information from us. So she was waiting for one of our staff to come out. And so her husband, who has Alzheimer's, he's in the middle stage. He was like, okay, it's time for us to go. Like he comes here so often, he knows where the elevator is. He knows that he was supposed to be leaving. And she's like, no. Like, we're going to be waiting for so-and-so. And so then he would sit there for a second. He's like, okay. He'd get up again. He's like, okay, time to go. And she's like, no. Just like, and you could tell she was kind of she's very kind and patient with him, but she just had to keep telling him over and over again, we're waiting for a staff member to come. But he didn't remember why. And he didn't even understand why they were waiting for a staff member. So probably over the course of the 5 minutes that they were there, he probably 3 or 4 times said, okay, well, like, it's time for us to go. So he seemed functional, but he didn't remember that they were supposed to be waiting for a staff member. And even when the staff member came, he then again tried, okay, well, like, okay, we're going to go. Like there's no stickiness in the memory. He couldn't functionally kind of get that. He was kind of confused and disoriented by, there's a routine. He's used to the routine. And the routine was being broken up because she just needed to wait to talk to the staff member to get some more information. Language and communication challenges. Like, people will not remember words at all. I mean, it's not like, oh, you and I sometimes forget a word. Like, they won't know how to communicate concepts or other things, So their communication may become very simple because they don't really know how to think of the words they want or even understand how to process the kind of thing that they're hoping for. Difficulty with basic activities of daily living, and specifically we mean like personal care. They'll have trouble feeding themselves, but also you may start noticing that they don't change their clothes regularly because they forgot, so they'll just put on the same clothes or put on dirty clothes because they can't tell the difference. They can't brush their teeth or shower. And some of them might be memory. Hey, Appa, did you take a shower this morning? Yeah, I took a shower. And then you go in there, it's completely dry and you're like, but he thought he did. He just doesn't remember. Or he's like, I need to take a shower. And you're like, no, we just took a shower 20 minutes ago. No, I didn't. And so like taking too many showers or washing their hands too frequently or things like that, So personal care can be affected, and it's common. They won't brush their teeth as much, other things. And this may also be because they're losing physical function and they need more help with it. And finally, there's safety concerns. Because first, you got to supervise, right? Because like if somebody's going to get disoriented, they may get lost. If they don't remember the function of an object, they may use the wrong thing. Remember I was joking earlier, like what if you were using a duster to try and make your eggs? But that's dangerous because you don't want a duster that has like feathers or something near an open flame, right? That could catch fire. So you have to be very conscious of that stuff. You don't, at this stage, people will probably no longer be able to be allowed to drive. Now that's not our decision. That's a decision the DMV makes. And you should be making that decision along with the person themselves as best you can. But at some point, they may not even remember why that's a concern, And again, at some stage, people will reach a point where they just need care all the time. So in this middle or moderate stage, people need a lot of support and care. And it can be exhausting on the care partners because you're repeating yourself all the time. You're having to help with daily functional things. You have to be driving people around and moving them around because they can't do those things for themselves anymore. And finally, in the late to severe stage, the brain is so affected, they can very limited verbal communication. There are clients of ours who come here for those activities, for instance, and 3 years ago, they would talk and interact, and now they just come and they just sit. They can no longer talk to our staff. It's really sad, but this is what happens. It's hard on our staff, I know too, because these are people that you watching your relationship dissolve. But that's not a fair way of putting it. You're still there emotionally with them, but they can't interact with you in the same way anymore. So it's tough, and this is hard on families. 24-hour supervision and assistance with all activities of daily living. Somebody who's in the very late stages, they cannot function on their own at all anymore. Because you're talking about no longer being able to communicate, no longer be able to understand how to get around and orient themselves. So there's severe safety issues that go along with that. Also, they may, I didn't touch upon this last one, wandering risk. People who are like that will just leave the house. Although at this stage, people have sometimes lost so much physical ability, they can't even leave the home on their own because they don't have that ability to do that cognitively or physically. So they need constant supervision, especially around the safety regards of things, And the very late and severe stages, there are people who are living with Alzheimer's right now who are no longer able to chew and swallow their own food because that part of the brain has been taken away. So you can't just give them a sandwich and they can just put it to their mouth, eat it, chew it, swallow it. They can't even do that anymore. So you have to have specialized diets and help them to eat food if you're going to keep them sustained. And again, they're still living people. We still have to feed them. They're still human being, but they are no longer, their brain is no longer able to cognitively, functionally be able to do that on their own. And finally, there's reduced physical activity and independent mobility. So in cases like this, you were asking about exercise, for instance, before, you might have to help them exercise and move around, And at some point, some people either end up wheelchair ridden or even bedridden because their body has lost that ability to control itself. And that is, again, inclusive of bodily functions like going to the bathroom, So, and that can become very extreme. People who are in the later stages, generally they need to have adult diapers and things like that because they can no longer control their bodily functions, So, and it's not uncommon in those kind of care facilities or with somebody who has very severe Alzheimer's for that to be that they just have constant bathroom accidents, if you will, right? Wherever it is. We had one last week actually after the social activities. And so we had to clean up the bathroom. It just happens. People just don't have the same ability anymore, and that's okay. But we have to be giving in ongoing support and care if this develops, right? So throughout the disease, people living with dementia, though, they can still make and communicate decisions. They still have autonomy, is the word we're going to use a lot more in the second section, but they're still people. They're still adults. We can't just strip away everything, Now, their ability to make and communicate decisions may diminish over time, but they will always have that, and they should always be trying to give that so we can honor the dignity of them as a human being. We can't just take away everything that they have, They may not be able to be independent and free like they used to be, but they can still be autonomous, and we can still honor their right to be able to be involved in the decision-making. They can still express feelings and respond to emotional connections. An interesting thing about the brain is the parts of the brain that are like tied to deep emotions are so deeply in the brain that never goes away. So you'll find, again, if you come for our social activities on a Friday, people are quite joyous and happy to be here. Now, of course, does somebody sometimes get grumpy or something if they're not feeling well? Yeah, those things happen. But people, you could still connect with people in an emotional way, And that's especially true with touch and other things. Music is really valuable and really helps connect people because the connection to music, the brain never stops for some reason. It's like so built primarily into our brain that it's always there. So use those things. They can still engage in modified work and recreational activities as long as it's safe for them. I mean, yes, there are people, I saw a little video recently about how in Japan, there's days where they have people with Alzheimer's work in a cafe. So like I would be a care partner with them and I would go around with them in the cafe, but they take an order and they write it down and it could be totally wrong. And they go and get the food and bring it back and it could be wrong. And everybody who goes to the cafe knows that it's okay to get your wrong order or whatnot, and somebody helps them, but you can still involve them in things, And I will say our society has a very unfortunate approach to that where we try to lock people with Alzheimer's and other dementias away. We shouldn't do that. We need to find ways of bringing them back into society and involving them in things because it's healthier for them and it's healthier for us. So they can still be part of our world. And finally, connecting through sensory and nonverbal communication. Touch is still a very important thing. If you have a touching relationship, sometimes you may not, and don't create that if it's not necessary. But music especially, like I was mentioning, is still a way to really connect with people. So keep that in mind. That yes, I'm talking about people going through some very difficult changes that are very sad and hard to witness. And it can be terrifying for us to go through it together as a family, as a group, as people who work within the community. But there's still ways of connecting with those people. They're still human. We still want to engage in that humanity and honor their dignity. So before I go into person first dignity, person first language, and some of the cultural considerations, any questions about what we just talked about in regards to the development of Alzheimer's and how it progresses over time? And I think the really key thing that I want you to remember as you train families and other people in our community is that if somebody has Alzheimer's specifically and they get that diagnosis, it's progressive, it's never going to get better, and at some point it will require 24/7 care. And I say that coming back to what we were talking about before, in that many of the families we may be working with, they may not be able to afford to bring in a caregiver, like a professional caregiver, or send somebody off to a residential facility. So that means that they are going to have to find out a way to plan for 10 years from now. They may have to 24/7 care for somebody in their home. That's just the reality of what happens as this disease develops. So person first language, we're really big around this here. And we encourage all of you to use this in your stuff, and try your best, by the way, because you can't force anybody in the community, but to use language that helps people to remember even some of the dignity we're talking about. So we here use the term person living with dementia. We don't call them dementia patients or Alzheimer's patients. We try to focus on the idea that they're still a person first and that they happen to be living with dementia. And we don't want to say a person with dementia, because that also kind of defines them as just the disease. And for one thing, they may have other diseases and other things going on. A lot of people who have dementia, especially Alzheimer's, have lots of other health issues going on. But they're a person who's still living with dementia. And again, I really emphasize that word because they are still living with it. We want to help them to live the fullest life that we can help them live with, right? And that's some of what you need to help train the families and other people you're working with on is, if somebody in your life has dementia, how do you help them still live a meaningful life? So part of this is also putting their experience first. We want to put their experience first and help them to still have that experience, So please avoid the terms demented. That still gets said sometimes. Nobody's demented. Demented means something different. Demented means you're like kind of evil or off track or whatever. But we shouldn't say, oh yeah, there's Mrs. Sanchez over there. She's demented. That's really bad. Like, this is an outdated terminology. So try to not use that in your own organizations. I'm not saying don't police other people's language, but maybe find ways, if you can, of discouraging people in our communities from using this. I especially say this because the Latino word for, the Spanish word for dementia and for demented are very similar. And a lot of people kind of use them back and forth. From what I've heard from some of my Spanish language instructors and Spanish speaking staff, is they feel like this is still very common. This is becoming less and less so in English, but still, I've heard older people still call people with Alzheimer's demented, The other term is senile a lot of times, and senility is a little bit different. But in this organization, almost nobody, we don't use the word senile. People aren't senile. They have dementia. They're living with dementia. We don't like to use the term suffering from, because they might be suffering from, but why emphasize the suffering part? Now, some people, that may be the term they want applied to them. If that's what they want, okay, because maybe they feel like they are suffering from it. I get it. But we don't want to imply that anybody is suffering, They're living with the disease. Let's focus on the positivity of the experience rather than focusing on the negativity of suffering from something. And also, we try to avoid patient, especially because we're not doctors. They're not our patients, so we try to avoid using that terminology in general. You hear us, we tend to use, again, person living with dementia, people living with dementia, and clients, but we don't really talk about people's patients necessarily because we're not clinicians. When it comes to people who are caring for somebody else, we tend to fall towards the term care partner, although the term caregiver is also okay. We do not like the term caretaker, because nobody is taking care away from anybody, They're giving care. But the reason we've kind of moved towards care partner is because due to changing circumstances, not everyone is a traditional caregiver. We don't like to assume that people are family members, because this is another one that comes up when people from externally come, like it's the families who are caring for them and things. This situation has become very complex in our communities, right? Again, Miss Sanchez, who lives down the street, she may not have any family here. Her family may have moved away or passed away or whatever. You may be a neighbor who's taking care of her, You may be a friend or family member who doesn't even live nearby, but knows that Mrs. Sanchez needs help, So be aware of that there's all kinds of different roles and situations where people are caring for others. Now, still traditionally, it's mostly still families, but don't assume that everybody wants to be called a care partner or caregiver. And I will say, and if Nellie, who popped by later, comes back, she may talk a little bit more about this. There are some of the Latino families we've worked with who don't like to be even called caregivers or care partners because in their mind, this isn't a thing. They're just a family member, and that's what you do to help your family, you know? So just be aware that, but we tend to fall more towards the idea of a care partner, you know, because it leaves it a little bit more neutral. Because again, people can be friends, family, or other community members, but also it avoids suggesting that somebody is a loved one, you know, because like the thing we're finding as we do our work, sometimes you don't love these people. And I don't mean because of what the cause of the disease, but also, you know, it could be that it is, you know, a father that you never really were that close to, who now suddenly, you know, we've encountered situations like that where the only child who can care for this adult is the one who is the least wants it, but is kind of forced in the situation. And so we want to be careful about implying, you know, that oh, you love this person. I know that sounds odd, but let them drive that conversation rather than assuming that you understand that. It seems compassionate on the surface, but the challenge is that it can be hard for people because not a lot of people don't want to be in this situation. No one of us want to be in this situation, you know. And for some people, they've been pushed into it for a lot of different kinds of needs, you know. For instance, in the LGBTQIA community, there's a lot of people who just don't have families because the nature of their sexuality means that they've been disconnected from their families. And so frequently, you're talking about people who are relying on a wider community. And for instance, I heard this directly from some people when I taught a class in Hillcrest one time, that for some of them, they've lost a lot of people over the years because of other diseases, AIDS, other things. And so a lot of them have these tiny little older adult communities, and they're trying to support each other as some of them are developing dementia. It's hard, you know? And again, it's not always family members. It's not always the assumption that it's a loved one. It's somebody who just may be somebody that you know you need to help in the community. So just be conscious of that. Don't assume anything around a lot of that stuff. So I think that's what we always emphasize is the key to success is the term they want to use for themselves, you know? So try to go in with a neutral term, but as you're talking with them, listen very carefully about how they refer to themselves and the relationships they have and try to echo that same language, you know? That's the best way that you're going to keep yourself from implying something that somebody may be uncomfortable or not happy about. You can also sometimes ask them what they prefer, you know? Especially if somebody expresses that they don't like a term you're using, accept that, that's okay. And then just ask them what term they prefer for you to use. That's okay. And so maybe they want you to call a loved one, or they want you to use the person's direct name or whatever else it is, you know? If you make a mistake, just be humble about it. There's just no right or wrong terminology. We're trying to encourage you to use more neutral, broad language, and then through this, try to specify and figure out what each individual needs, each individual situation needs, which means you're going to make some mistakes. So just don't assume that you know better than anybody else. They know what's best for their situation. Know that every person you're going to be working with around this is going to need a unique approach because the disease is going to affect them differently. Dementias are going to affect them differently, but also again, their care situation may be different. You don't always know, and we can't always assume, you know? Again, for a Latino household, you may assume, oh, well, then your mom lives with you, but she might not. You know, so just always be conscious of the fact that also you may not know what their situation is. And this is especially true as we think about other kinds of ethnicities and other groups that we may work with. We may just not know what their situation is, so don't assume. And if you make a mistake, just be humble about it and say that you're learning as well, you know? And finally, just try to build an authentic relationship. If you're really trying to connect with the person and showing that you're humble, showing that you're trying to learn about them, that counts a lot more than using the right language all the time. Figure out what you need to have and work with that person specifically, you know? And that's also in some ways what you want to help the families to do because they're going to need to drive and change some of their ability to care for somebody in this way. And the more that you can really know a person well, the more that you can help with that. One of my instructors uses a really good example. She doesn't like to sleep with socks on. It makes her very uncomfortable. And so she's told her husband, if I develop dementia, please make sure that they take my socks off when I try to sleep because I may get to a point where I can't communicate about that anymore. And lots of care partners, especially professional caregivers, just assume these sorts of things. And those little details like that are the kind of quality of life opportunities that help to put on the right kind of music at the right time of day. Those little sorts of things, you know, those little details. So try to get to know people because this is a journey that they're going to be having to take too. And the more that they know their other person there, you know, which is funny. I'm thinking about this, like I should do this with my dad because he's getting older. Like, what would he prefer? But we don't ask those questions, and sometimes we don't ask until it's too late. But that's the same on your side too. You know, like help them and help yourselves to think about how do I develop that unique personal relationship to help this person the needs they have. Because again, everybody's affected by dementia differently. And when you talk about a long-scale disease like Alzheimer's, where somebody may be living for 15 years, let's say, and this is only getting worse over time, trying to drive these so that the person can still have a high quality of life as best as we can provide for them, you know? So what are some of the cultural considerations we may take around that? Well, so for one thing, keep in mind that talking about the disease might be different for different people. There's still a lot of discomfort and stigma around Alzheimer's and dementia as a wider whole, you know? So just be conscious of the fact that some people, I mean, I've talked to people who are, you know, Caucasian, who are very, very uncomfortable talking about dementia and talking about Alzheimer's specifically, because it freaks them out, you know, and they've seen it either up close or even just sometimes at a distance, and they're like, "That's just, I don't. If I talk about it, that means it may even happen to me." It doesn't necessarily mean it will, of course, but so just be conscious of whenever you're interacting with somebody, their comfort with this disease could be that they're okay with it. I'm very open to talking about it, but I lived through it with my grandmother. Some people, it's just really frightening for them, and it's frightening them because they did live through it and they don't ever want to deal with that on their own. So just be conscious of that. The other thing, though, is that there may be family or social hierarchies that we aren't aware of. So this is something that this organization has tried to adjust for. Is traditionally the organization really, you know, mostly worked with people who were more affluent and white. So it was very common to say, you know, like, okay, so like when you're when you treat your, you know, when you're working with your mom, you do it this way. Well, that might not be acceptable in another culture. You may not be able to say that or do that. Now, I will say, you as having to train people to start becoming more comfortable with certain kinds of caregiving, you might have to encourage them to do some things that they're not comfortable with based on social hierarchy. But we should never assume that we know what those hierarchies are. You know, some families is very open and you know, and some of this has to become personalized because it can be a family situation. But I will say, for a lot of us in this room being Latino, like in my family, we weren't really supposed to question my grandmother around things. She was the matriarch. She was the one who ran the family. Well, what did that mean though, when she was the one who then developed dementia and could no longer make safe decisions for herself? And my dad and his generation really struggled with that because you don't tell her what to do. And she didn't want to be told what to do. But you can't do that if she's going to do something that's unsafe and that would not only put herself, but others, including family members, at risk, right? So just be conscious of that we don't always know what people's social hierarchies are in certain kinds of families. And not just the unique families, but also culturally, there may be different kinds of approaches for that. Again, something that our organization is becoming more comfortable with is understanding that for some families, the perception that putting somebody into a home is completely unacceptable. It was a real struggle for my family, and my family on the whole had the ability to do that. But it was they tried as far as they could to try to take care of her at home, because the idea that they would put their mother into a care facility was like the last thing that we should ever do. They weren't being good kids at that point if they were having somebody else take care of the person who raised them. So us always trying to be conscious of that and know that it's different for every kinds of different the unique families and the unique care situation, but also there might be ethnic differences that you may or may not be aware of. Because you may not also only be working with Latinos, you may be working with people who are from Asia, for instance, you know. There's a huge Southeast Asian population in San Diego, right? Like, you know, San Ysidro Health and San Diego PACE in general has a heavily influenced national city. There's an enormous amount of Filipino people there. And yeah, there's a lot of parallels between our cultures, but there's also a lot of differences. So we should never assume those things. You want to try to get to know their situation and find out what's going to be comfortable for them. Also be conscious that a clinical approach might clash with other cultural values. This is something that the instructor who popped by, Nellie, she and I talk about this all the time. A lot of our classes, for instance, talk with this heavy clinical approach up front. Here's what a brain looks like. Here's what the brain's affected. Here's all the different names for these different parts of the brain. For some people, that's like, and I'm not even trying to say that on an educational level. It has nothing to do with level of education. It just may be that that's not the way that people want to approach it, especially in almost every case, regardless of somebody's cultural or ethnic background. They're more conscious about how much they care for somebody, or maybe don't care about somebody, than they are about all the clinical stuff. So maybe instead of trying to push the clinical stuff first, bring that up later. Try to instead focus on what are you going to do? What's the plan you need? What kind of support are you going to need? How are you feeling about this? Those sort of things, you know? That may be a more important thing for these situations. In regards to just promoting health and safety, lifestyle habits or living environments might be different than what we expect. So I'll give you a specific example, something we changed in our Spanish language curriculum. In our brain health classes, we used to specifically teach, in the English version of those, that people should adopt what they call the SMASH diet, which is a diet that's heavily fish-based. And SMASH stands for salmon, mackerel, anchovies, sardines, and herring. I, as a Latino, have only eaten one of those fish in my entire life. Maybe two of them. Maybe I've had anchovies at some point. I don't know. But I've had salmon. But most Mexican-American families like mine do not eat salmon, in my experience. I don't want to assume for anybody. But so for us to go into like San Isidro and be like, you should eat these 5 fish, is it comes across as kind of a little bit culturally ignorant on a certain level. It makes sense for a certain area, and those are healthy things to eat, but maybe just encouraging them to eat more fish in general, more seafood in general, or to try to eat less red meat instead of focusing so much on eat these fish. So be conscious of that people's lifestyles and habits and behaviors may be very different than what we're expecting. That's especially true in terms of safety, because there may be things like, for instance, when you're living with somebody at home who has dementia, you need to take into account a lot of safety situations. There's a lot of things to be conscious of because people might leave the house, they may get disoriented, they may have access to things like chemicals or tools or other things that might be dangerous for them. Some households have guns in them. You don't want somebody who has poor judgment to have access to a gun, right? And we actually offer free gun locks, by the way, if anybody is ever in a situation like that. So, and they don't even need a diagnosis. If they say they need a gun lock from us, we have them for free, So safety, though, becomes this critical thing, but people live in different situations. Again, I have Vietnamese friends who, like, if you enter their home, you can't wear your shoes inside the front entryway. But it could become a situation where somebody in the home does need to wear shoes, But we have to be conscious and careful about navigating those things because we may not fully know what the home environment is, and we can't judge their home environment on that. We have to take the neutrality of understanding it may be different than ours, but we need to help them to start understanding steps they need to take to care for the person that they have in their life. Also keep in mind that expertise can be intimidating. This is something we found a lot as we've been trying to expand our work. We tend to focus on expertise. We know all the stuff, clinical things, all that stuff. That can be intimidating to some cultures who don't regularly discuss this. My father in 2019 and my father's a college professor, by the way, at San Diego State. In 2019, he developed leukemia. Super tragic. Now, fortunately, he lived through it. We're extremely fortunate around that. But I will say that, like, the expertise for some of our family members was intimidating. Like, the doctors knowing all this stuff was kind of scary, so they just didn't want to get overwhelmed. On the flip side, also the expertise in some cases led them blindly following things without understanding why, and sometimes then doing it wrong because they were just doing what they thought they were told. So I was actually talking to somebody who was an assistant in my healthcare system one time. She and I were just chit-chatting about stuff like this as I was waiting for the doctor to show up, and she said that she's Latina. Her mom or grandmother had heard from a doctor one time that she was supposed to be taking Tylenol every day. And so she was just taking Tylenol every day. It's really bad for you. So it's damaged her kidneys. But she just didn't question the doctor's orders, but didn't understand them properly either. So that blind following of the expert has now caused a new health problem for her. And I'm not saying that's for everyone, but sometimes people can be like, oh, this is too much, like, too much, and it's scary to me. On the flip side, it's like, okay, you know everything, I'll just do exactly what you tell me. That's also not healthy, right? Like, with the situation where with Alzheimer's and any kind of dementia, but specifically with Alzheimer's, where each person is going to be unique, we have to cater the caregiving and safety and realities for that person. So no expert is going to know the expertise for just the individual. We need to work together to craft that sort of thing. So be conscious of the fact that expertise in some of these situations isn't necessarily valuable, It's not bad either, but don't pour that knowledge at them. Use it where it's useful, Living situations. We kind of touched upon this, but there's a lot of cultures where having your elders live at home is like the most important thing you can do. That the idea that you would send somebody away is like very, very intolerable. And we've experienced that. We've had people get very frustrated with us when there's the implication like, well, when you start considering a residential placement, they're never going to consider that. No matter which way you think it's going to happen, even if you're trying to explain to them, look, at some point, your grandmother is going to be in this situation where you're going to have to care for her, feed her, take her to the bathroom, bathe her. And for some people, it's like, that's my responsibility to do that. There's no question that I'm the only one who should be doing that, So just be conscious of that. The certain family structures, they're not going to want to hear different than that. And you should try to honor and help them with that as best you can. If they come and change their mind later, that's up to them. But we can't force them to think and perceive it in the way that we do. And this is especially finally for this last thing, death and dying. We cannot assume that there's going to be relief when somebody passes away because of this. That's something that I've seen taught in certain areas where it's like, Oh, and then you'll probably feel this huge sense of relief when, they pass away after all this stuff. And see, some of you are already nodding. When my grandmother passed away, I felt a sense of relief because I'm kind of the jerk in the family. I'm not gonna lie, So I was like, she'd had dementia for like 10 years. Like, we knew that she was going to pass away eventually, but that's me. I'm also half Mexican, so like my white side of the family is like really, really like they're like just like very unemotional. But the Mexican side of the family with my grandmother there, I mean, my aunt, even though she had been caring for her mom at the end there, and they had her in the home, and it got really difficult. My grandmother was escaping the home and stuff. She ended up on the freeway in a wheelchair one time, like just on her own, like on the scooting down the freeway. I mean, really difficult stuff. And yet my aunt threw herself on the casket. She was so sad, and there was never going to be relief. It didn't matter how difficult the disease was getting for us to take care of her. Nobody ever wanted her, the family did not ever want her to go. So we can't assume that we're going to understand people's feelings at the other end of this journey. For some of them, that care was become so meaningful. And even here sometimes, I mean, one of our staff recently lost their parent, and they're really struggling with it, because they started to build and define a life around that. Now it's just gone. So don't ever assume that we understand the feelings, but especially relief. The other side too is there may be cultural beliefs that affect perceptions around compassionate choices. And what I mean by that is that, like, there are options for people if they're at the end of their life with certain kinds of diseases, And so assisted suicide and other things is what I'm directly speaking about. And I'm saying this because some cultures do not want to hear that. Again, the Mexican side of my family is very deeply Catholic. You would never, ever bring that up in that conversation. Never. That was never an option. That was never going to happen, So we should be conscious of that there are different kinds of cultural choices out there. And some people may feel very comfortable with this. And some people may be even offended at the idea that you might have even brought it up. So we want to be very conscious of the fact that we can't assume that everybody's open to these ideas. And we should try to find out what they are comfortable with and find the pieces of care and support that we can give them that they are open to. And again, they might change their mind later around this. I should also be very clear, if somebody has dementia, they're no longer able to make that kind of capable choice. So people with dementia are not allowed to take that choice unless there are certain things that are written out. And it's very complex and very difficult to deal with. So I don't want to imply that this is that people who have especially severe Alzheimer's or other kind of later stage dementia have this choice. They actually really don't. But this topic is one that does come up sometimes. I was just at a presentation recently about this with some of the organizations in San Diego who provide information about these compassionate choices, end-of-life choices. And some people aren't comfortable with any of that, and we understand. So again, never assume on that. I mean, that's always the better underlying thing. Never assume.
I have a question.
Yeah.
In your experience, what are some of the compassionate choices that have kind of been an area of contention where culturally they may not be as accepted?
With end-of-life choices, almost all of it can be frustrating. And that's not even just, I don't want to make that just about people of color versus, it's everywhere. People are very uncomfortable based on religious things, all kinds of different choices and things like that. So, so I will be honest, I come from a kind of non-denominational background and I'm very open to this. And so I work with those organizations and I'm trying to learn more about it. But I've also come to rapidly understand that lots of people don't want to have that conversation. And that makes sense, Now, I am not an end-of-life choices expert, so I can't go really deeply into it. I rely on those kinds of organizations to inform people. I will say Alzheimer's San Diego is really a big hub for a lot of stuff. There are some direct services we offer, and I'll talk about those at the end of our presentation. But that said, some of the stuff, we pass them back. I mean, I'm not an expert on PACE. If somebody's really inquiring about PACE, I find out what area they're in, I send them to you. So just be aware of that, just in the wider whole. So sorry for kind of a vague answer there, but yeah.
Did you say end of life, are you talking about hospice?
No. Although that hospice and other stuff, I should have mentioned that, even palliative care and things like that. For some people, they don't feel comfortable with that either. I mean, hospice is again that's a tough choice for a lot of people, right? Now I'm not an expert on hospice, but the reality is that for some people, you're also having to acknowledge that, right? Hospice is supposed to be for the last 6 months of life. And so that you're telling somebody they're probably not going to live for 6 more months. I mean, that can be very hard. So some people don't want to cope with that. So you can't force anybody, We can just offer them the best tools we can. And for us to be culturally adaptable, we have to accept that some people, that those may not be choices that they want to make for whatever reason. I would say the thing that we've encountered in my experience so far, I mean, if Nellie's able to join us later, that'd be helpful because she is doing this more directly. But again, some of the things around residential choices, so living at home versus other sorts of things, around, again, certain kinds of end of life choices and stuff like that, around diet and things like that. It's like, we can't just assume, and look, our organization is really great. We've been doing this for many years. Like we have all this great information, but we are having to adjust it as we connect with new audiences, because we can't assume that how we used to teach it for people in La Jolla is going to be the same as how we teach it for somebody in San Isidro. It's just not the same. There's different cultural realities that affect that, For instance, for some people, they live a more binational reality, and so that may affect the way they perceive some of this, And so they may actually be open to the idea of getting care, because in Mexico it would be cheap enough that they can do that, and they live a binational reality where they can go back and forth and it's not a big deal for them. Whereas some people here, it's like, I would never consider care just for the financial reasons. I don't have that kind of support. I don't have that kind of money. I can't bring in a caregiver to support me, let's be honest, caregiving is really expensive, so. And so finally, that's the thing, is we have to just keep an open mind. Most of the time, errors that come from assuming that people think like we do, right? That our way is normal and that somebody else's way is different. There's just a lot of different ways to do things. And so if we can always back up as we're interacting with our clients, interacting with these families, and also even somebody's helping them to start becoming more adaptable, because the person that they may be helping to care for is going to be changing, right? As these diseases progress. So sometimes it's just best to ask before assuming. And some people may feel a little rude that you asked, but sometimes that is, at least you're setting a better starting point than assuming that you think you know and then making a mistake later. And don't assume that your expertise translates to their experience. Just because you know something doesn't mean that their experience will connect with that necessarily, Again, I experienced that a lot with my father when he had leukemia, was that like, there was a lot of, they were just kind of pouring information at us. And a lot of times it was like, how do we mesh this with how he lives? And he was so overwhelmed by all of it. And so it was hard to kind of, but the healthcare system is just assuming that we understand these things. No. There's lots of things we didn't understand, lots of things that we weren't prepared for and all of that stuff. It didn't mesh with the experience we had, And finally, being inclusive means putting yourself aside sometimes. So, we want to try and create inclusive environments where anybody feels welcome to come and get support and services from us. And that means that sometimes you have to be very humble about this, that you're going to make mistakes, that you don't know all the answers. And finally, that you have to learn from those you're supporting, that the people who are the experts about their experience is those people. So you kind of have to put yourself aside sometimes, So now there's going to be cases where they do ask you to be the expert and the knowledgeable one, But there's going to be times where you need to learn from them and acknowledge that you need to learn from them so you can use that expertise to help them to figure out what they need to do and it's going to be best for them. So that's the end of part one. We're going to take a break now, but before we do that, do we have any questions before we move on?
I have a question. What is the difference of what is versus Parkinson versus Alzheimer's versus dementia?
Parkinson's is not a type of dementia. Parkinson's is a different disease. It is a cognitive disease, but I'm not an expert in Parkinson's. But Parkinson's is not a type of dementia. Alzheimer's is a type of dementia, right? So one of the ways we talk about this, I should have put the graphic in there. Dementia is like an umbrella, and there's all kinds of dementias that fall underneath that, So again, there's like Lewy body, there's frontotemporal disorders, there's like, for instance, if you have a serious vascular issue, like with your heart and your blood system, it can affect and damage the brain, and then you have forms of dementia. You can't remember as well, you can't process as well, and things like that. I used to work with somebody who was in their 20s, and they had a traumatic brain injury. They got into a bicycle accident, and their brain was damaged. So they had dementia. And so they were an employee of mine, and they led tours. I used to work in museums. So you think, well, if you're going to lead a tour, you need to be able to memorize and repeat information for people. And this young person couldn't do that because their brain had been damaged by the traumatic brain injury. So they would have to take really extensive notes. And when they did a tour, they always had their notes with them. They would type them up and get them all prepared because they couldn't remember as well. But over the 5 years or so that person worked for me, they got better. They never went back to probably how they were before. But when I first started working with them, they would forget short-term things. They would have a hard time remembering words. So I would be talking to them and they were like, you could see them kind of look up and sort of trying to find words and stuff like that, way more so than somebody who's in their mid-20s, she would take a lot of time to process things and think through things, But then later, she was a lot more vocal. She was able to talk much more easily. She would still always write extensive notes, but that's the thing is, a traumatic brain injury can cause dementia, but her brain started to find solutions and work around that as she practiced with that. The challenge with that compared to Alzheimer's is Alzheimer's just continues to strip away the brain, you know? And so you're just going to continue to see loss of function and cognitive function over time. But Parkinson's is not related to any of that. Parkinson's is a different cognitive change that doesn't cause the same things. There are some slight overlaps. I don't know what they are off the top of my head, so please don't quote me on that. But they're different. It's a different loss of function. So, yeah. Sorry, that's not a super exacting answer, but I'm not on the heavy clinical side for that, if that makes sense. Yeah. And there is the possibility that people can be affected by Parkinson's and dementia, including Parkinson's and specifically Alzheimer's as a disease. So that's unfortunate because people are then affected by both. And Parkinson's has a strong effect on the physical, you know, like there's like, you know, shaking and stuff like that from my understanding. So, yeah. Any other questions before I give you a break for a little bit here?
For your classes for people interested in the services,
Yeah.
how does that work?
So everything that our organization does is free. So anybody can just come and take classes or call us to get services. They can come to the office to get services. Look, I'm also going to point out, so we are now moving some of the classes down to San Isidro. We're going to do in January, March, and February. I think it's in February, we're going to do at least one class at the San Isidro Library, and we're going to be doing monthly classes at the Otay Mesa Nestor Library. So we're trying to do more classes down there. All those classes will be in Spanish as well. And if we see more success there, we may offer some classes in English as well. So all of our classes are free to just come and take. We ask that people register ahead of time through our website because it helps us track their information. But anybody can drop in. We take registrations there as well. You know, we do ask that everybody register because that's how we get money, is we have to track everybody individually. And then for the rest of our services, like let's say somebody is like already dealing with this, like their husband has already developed dementia, they're struggling, they can't even get out of the house, they should call us. And so if you call, they can talk to our support team. The support team is available from 8:30 to 5 Monday through Friday. And if after hours, they can leave a message and we'll call them back. If they speak another language, we have translation services. And also I think we have like 3 or 4 different staff members who are fluent in Spanish as well. So if you're working with somebody specifically who speaks Spanish, who needs that support and help, they should give us a call. And from there, they can cater all kinds of things. That's why this organization is so great, is we can do all kinds of individualized help, whether it's guiding people towards the kind of caregiving stuff that they need, like maybe they need to bring in a company or something, find residential options, find legal options for dealing with some of that. We can help to specify a lot of that stuff. And we have certain kinds of programs like support groups and things like that. So the end of the next slideshow, I'll give you an overview of our services that we can talk about. But if you, and I don't mean individually, but even as an employee, need help with these things, you can always call us. That's what we're here to do, is support all of you, not just the family members and caregivers, but everyone in the community who needs this support. So if you need follow-up to some of these questions, if you really want to get a detailed answer about the difference between Parkinson's and Alzheimer's, give them a call. They'll talk to you for an hour about it if you want, you know? They know that really in-depth stuff. So, and everything we do is free. So, yeah.
Okay, I'm asking because we have the daycare centers.
Yep.
Our days.
Yep.
And families feel like very supported with the daycare center.
Yeah. Yep.
But some of them work and they need the extra help to manage their loved ones after they leave the center.
Oh, absolutely.
So that's
Yeah, yeah. Now we don't provide a ton of that kind of direct support services. We're not that.
What you're saying right now, it would be great for families to know.
And the whole next section is all going to be training you about all the ways that they can implement those, so you can learn those tools and train them on that stuff as well. But also, if people are looking for that, we can help guide them. If they call us or even come for a family meeting or something, we can guide them towards services that might help. You know, some of them you're probably aware of. For a lot of people, we try to guide them towards IHSS, right, to in-home supportive services. But again, I was just told recently by somebody that there's an in-home supportive services worker shortage, and not everybody's getting the support they need. You know, it's a huge shortage. So, but so we understand. So that's why we try to focus so much on the two parts: educating people about how to care for people, especially if they're living at home, and what other options are out there if they want to consider them. But then also call us if you need more detailed support around things like that. You know, because we're going to get into some of that in this next section about where people need to kind of apply a lot of that.